So firstly, thank you to DJO Chattanooga for providing me with this opportunity to build on Professor Jim Richards' excellent talk on patellofemoral joint syndrome. My remit today is to provide you with an evidence-based clinical management strategy for patellofemoral joint syndrome, with emphasis placed on the subgroups we identify as being weak. So what do we mean by a multimodal approach? We are combining interventions to address instability, neuromuscular control, and proprioception. Now, we've learned that bracing can help with instability and would be pertinent for all patellofemoral joint syndrome patients, but especially those who have been assigned to the fit and strong subgroup, as prescribing strength and exercise is clearly not relevant. Now, I do get asked the question, but how do we overcome a patient becoming reliant on a brace? Now, my immediate reaction is, so what? If a brace is allowing a patient to continue to undertake the functional demands they wish, then what is wrong with them wearing a brace? Especially these new lightweight web design braces are perfectly comfortable and applicable to most recreational activities. And what has been shown is that they not only provide stability, but an afferent stimulus through the skin to improve proprioception. Have a look at this video. We can see the same stability test on a Huber 360 platform with and without wearing the reaction knee brace. The results show a significant drop in movement around the center of pressure and the area of movement. And the report clearly shows a significant increase in stability of the knee while wearing the brace. However, if the patient does want to stop wearing a brace, then encourage them to wean themselves off it. It's not good practice to suddenly stop, so consider using taping, which, like the bracing, provides an afferent stimulus to the brain. And for those of you who prefer to use tape, then understand what it's doing. We know from imaging that it's not altering the patellar position. There are some EMG studies that show an increase in EMG activity within vastus medialis with the tape. What Linley showed us in 2015, he being a PH student of Professor Jim Richards, is that tape provides an afferent stimulus to the brain. Linley showed with the help of fMRI imaging that having tape on the skin results in both the sensory and motor cortexes of the brain lighting up at the same time. So he went on to propose the skin-brain muscle principle, where a sensory stimulus on the skin can result in increased neuromuscular control. In Professor Jim Richards' lecture, he talks of comparing different sensory stimuli, including McConnell taping, tubie grip, and what he refers to as plonk taping, where a piece of tape is randomly affixed to the patella. And all of these interventions had the same positive effect on knee stability during a step-down test. So clearly it's the sensory input that's driving the effect rather than the technique of application. We're all aware of the need for good proprioception, and we will consider how our interventions can be enhanced a bit later. So moving on to neuromuscular control, you will all have your favorite exercises for this. Will know the importance of working through the kinetic chain using functional exercises and optimal loading. One major consideration, though, is that your exercises will be working all of the quadriceps, and you may be wanting to put more emphasis on vastus medialis to address an imbalance between it and vastus lateralis. Most EMG studies agree that despite changes in foot position or using open chain versus closed chain exercises, both the VL and VM are activated without bias towards the VM. A study by Mio et al. 2015 suggests that using resistance band to promote adduction will increase EMG activity in the VM compared to the VL. We must also consider the patellofemoral joint loading through range. There may be a specific range of movement that elicits the patient's pain. So we should consider interventions to help reduce patellofemoral joint load by reducing body weight. For example, supporting the trunk, sitting on a gimbal, or I know of some clinics who use harnesses to get this effect. So although we place much emphasis on neuromuscular control, it's only one factor in a complex issue. Hence why I refer to patellofemoral joint pain as a syndrome being a set of medical signs and symptoms that are correlated with each other. There are many factors that singularly or collectively can result in patellofemoral joint pain. It's not just about neuromuscular control or imbalances. Indeed, these issues may not even be relevant. Watch this video. This child is suffering from cerebral palsy and has some obvious neuromuscular issues, but it's asymptomatic for knee pain. For those patients we've assigned to the weak subgroups, then the evidence does support the need for strengthening the quadriceps, especially the vastus medialis, which tends to be weaker, has atrophy, and has a delayed onset compared to vastus lateralis. Studies also show us that combining neuromuscular electrostimulation with our functional exercise prescription does enhance our outcomes by promoting more strength gains and muscle volume than in the rest of the quadriceps group. To help us understand why this is, we need to revisit our anatomy. Thirungama back in 1998, through dissection, showed us that vastus medialis is innervated by two strands of nerve coming from the femoral nerve. One is thick and short and innervates the superior third of the muscle. The other is long and thin and innervates the distal 2/3 of the muscle. For this reason, the vastus medialis has been referred to as having two parts, vastus medialis longus and vastus medialis obliquus, although it's only the VMO part we ever tend to hear about. It is not a separate muscle. VMO is not a separate muscle. Vastus medialis does have fibers which run obliquely and blend with the medial patellofemoral ligament to stabilize the patella. I think it's very unfortunate that some authors and indeed some therapists refer to vastus medialis as VMO. So putting that aside, let's see how we can use that knowledge to enhance our outcomes by incorporating neuromuscular electrostimulation with our functional exercise. We know that the distal portion of vastus medialis does have a separate nerve supply. So by placing our muscle stim electrode over the motor point for this nerve, we can now provide more neural stimulus to this part of the muscle to activate more motor units and fire more muscle fibers.
A really common dysfunction with the lunge is where there's a poor ratio between the vastus medialis, the inside quad muscle nearest to the knee, and the outside quad muscle, the vastus lateralis. This muscle is much bigger in size, however they should be working at a 1-to-1 ratio, and that's to avoid knee pain. During the lunge, if you're feeling the quads contract only on the outside, it means you need to apply the complex unit in this fashion right now for your lunging and your squatting. If we go into a lunge right now, what we can see is that the inside of this muscle and the complex unit is helping us contract the vastus medialis, and that's going to help you build up an awareness and strength on the inside of the quad so that you can balance out the 1-to-1 ratio that you need.
We can also recruit far more motor units and muscle fibers that can be achieved voluntarily. It will allow us to lift more weight.
On your own, you were able to lift how much weight?
37.5.
37.5. So here with the complex supporting the leg, we've got 50 kgs on the stack. Lovely.
So an example of how we can combine muscle stim with our functional exercise. Apart from just strengthening a muscle, we must also ensure correct movement control. If we have a weakened muscle in our kinetic chain, the brain will find ways to compensate. Then these compensations can result in pain and reduced function. For a long time, we have taught movement control exercises by providing visual, auditory, and tactile cues to our patient. With this method, we are teaching the conscious part of the brain. The patient, with repetition, learns the correct movement patterns and their pain and function improves. Only to find that when they go back to work or sport, where their conscious is now occupied elsewhere, they once again lose the movement control. So there is a move now to emphasize teaching the subconscious part of the brain. Ben Jasmins in 2015 suggested that the best way of achieving this was by an external focus. And muscle stim can be considered as such an external focus. We can place the electrodes over the muscles of the force couple, for example, gluteus medius and vastus medialis. Then by using a time-delayed program, such as the ACLR program, that's if you have it, if not, then use the MI action function, is a reasonable alternative. The patient learns subconsciously that by firing their stabilizers first, followed immediately by the mobilizer, this significantly improves their symptoms. So in this example, we see classic Gina valgum presentation. We're now applying one channel on gluteus medius, which is our hip stabilizer for a small knee bend. We're going to place a second channel on vastus medialis. This is the muscle that we want to use to control the alignment of our patella. So we find glute med fires first, followed by vastus medialis, and immediately we see a better functional outcome. To ensure these corrected movement patterns are embedded in the subconscious, we need to challenge the conscious. Dr. Cheryl Calder from South Africa taught me that we should treat the brain like a muscle. During periods of activity, it will get weaker. So we need to encourage cognitive challenges during our rehabilitation exercises. And we may start with a light exercise, for example, just catching a ball, progressing to reciting your 12 times multiplication table backwards, singing a song while counting. Have a look at this example.
Incorporate automatic pilot. So what I'm going to get Nick to do is to do a step routine that he knows. I like this one because it involves turning It's an important skill to have to protect your ACL, to be good at turning. And stop, but we're going to make it more tricky for him by asking him to sing while he does it. Off you go, Nick.
Today's going to be the day that I'm going to throw it back to you. By now, you should have somehow realised what you got to do.
And stop, that's lovely. Now, this is really tricky. On every 8th step, he's got to sing, but also count, because on every 8th step, he's going to change direction. Here we go.
Today's going to be the day that I'm going to throw it back to you. By now, you should have somehow realised what you got to do. I don't believe that anybody feels the way I do about you now.
And stop.
So exactly what is neuromuscular electrostimulation, or muscle stim as we refer to it? All muscle stim is an artificial way of reproducing an action potential by changing its resting potential. With the Chattanooga technology, the impulse used 98% mimics that sent from the brain. So indeed, the muscle does not know or care whether the impulse is coming from the brain or a machine, it's just going to react to it. And by changing the frequency of impulse, we can influence which fiber type is stimulated. And by changing the intensity, we can increase the number of muscle fibers and motor units that are recruited. We can use our muscle stim early in the patient management by using it as a diagnostic tool. The therapist in the forthcoming video has observed the delayed recruitment of vastus medialis on a patient's affected side compared to the unaffected side. Now, I will point out she does make a small error when she suggests increasing the frequency, where she actually means increasing the intensity in order to get better muscle recruitment.
So I'm just choosing the patellofemoral program on this particular clinical unit, and we'll turn the units on. And then when we turn them on, we're just going to go through a warm-up phase, and it's just the system using its scanning program so that it can test that yes, we've got a good placement of those electrodes, and then we can start the program. So I'm just going to turn them up. This program has a contraction phase and a relaxation phase, and it just goes sort of straight into it. So we're just going to turn it up, and interestingly, even though it's now in its relaxation phase, you'll see when it comes into its activation phase, just in this beginning area, that we've got an earlier contraction on the right hand side than the left hand side. One of the things that I've sort of found in being able to use this in a diagnostic phase, again, is that the patient can see, yes, my unaffected side switches on quite early because it's got good, muscle control and action, whereas the affected side is a little bit dampened down. So what it might need is a little bit more stimulus to activate it. So what I'm going to do, the moment they're on the same frequency, I'm just going to increase the frequency of the left to match that, so we can start to see a little visible muscle contraction.
So clinically, I use my muscle stim diagnostically in the same way. But if delayed firing is not obvious, then I use my motor point pen as a diagnostic tool. What I do here is I find the motor point on the unaffected side and then reduce the intensity to the minimum value to elicit a contraction at the motor point. I then move to the affected side, and if there's not a neural issue, then the minimum value should be the same. But more often than not, we find it can take significantly higher intensities to elicit the same response over the affected motor point. Now, we've seen a couple of examples of how we can combine muscle stim with active exercise. And here I'm showing you another. But earlier I said I would show you ways of enhancing proprioceptive awareness. And again, muscle stim is the answer. Look at the difference in outcome with this patient doing a balance exercise with and without muscle stim. Now, it should be stated that we were not using a frequency to promote a tetanic contraction here. We're actually using the endorphinic program, which comes under the pain programs, and it works at 5 Hertz to promote a sensory stimulus to the brain. So that simply leaves me to say thank you so much for your attention and giving up your valuable time. I do hope this talk stimulates some debate and hopefully will inevitably raise some questions, which if you send to DJO, I will gladly respond to. I look forward to presenting to you face to face again in the future, but in the meantime, please stay safe and well.